कॉम्प्युटर ऑडिओ. हां, माझा आवाज येतोय का आता? हां, ठीक आहे. अच्छा, अनेबल टू स्टार्ट व्हिडिओ म्हणजे तुम्ही ते स्टॉप केला आहे व्हिडिओ. हां.
हॅलो सर, तुम्हाला आवाज येतोय का?
हो हो, येतोय ना आवाज आता.
हा, ठीक आहे.
हां,
चालेल. मग मी सर ते पण असेच पाठवू का, तुम्हाला जशी ईमेल आली आहे तशीच?
हां, ठीक आहे. मला पाठवून द्या, मी
चालेल.
फॉरवर्ड करतो. हां, डॉक्टर
त्यात अजून थोडं
जॉईन झाले.
ठीक आहे, बरं.
हां
हां, ठीक आहे. चालेल, मी पाठवून देते. फक्त थोडा वेळ लागेल सर, एक 5-7 मिनिट तरी कमीत कमी अजून लागतील आपल्याला.
अच्छा.
Hello.
बिकॉज हे
Hello, Chandrasekhar, I'm here.
Yeah, you can start your video.
Okay.
Okay.
Thank you.
Okay. I will send links to Mansi. Send me the emails and then.
Yes. I'll do that, sir. I'll just send you the links. So Dr. Raj Shah's link, email ID, if you can resend me, please. I'll be able to give you the link.
अच्छा, ठीक आहे. आधी तर जे यांना आहेत ना त्यांना येऊ दे.
हो, त्यांचे पाठवून देते.
हां, आधी त्यांचे पाठवून द्या.
आजचे जे आहेत ते.
हां, जोसेफ बर्गर आणि हां.
हो.
So I will be introducing the first case, Mishram.
Yeah.
That is Neetu Ramakrishnaini. Ramarakhini.
Ramarakhini, yeah.
Ramarakhini. It is she or he?
He.
Neetu. She is from where?
I think she's Rahul knows her. I don't know.
Okay. But you will be introducing in the beginning itself, isn't it?
Yeah.
Good morning.
Hello.
Hi. Hello. How are you? Joe Berger here.
Achha, Joe is here.
Good morning. Good morning. I'm Dr. Satish Chandra here.
Good morning. Nice to meet you.
Good afternoon. Hello, Joe.
Hello. How are you?
Yeah, good.
Good.
Achha, you had no problems in joining. Jack has joined and okay, and Jack.
So okay.
Yeah, hello.
Wonderful.
Yeah.
Hello. How are you?
Yeah, good.
I'm fine.
I think Professor Visser has not yet joined.
Sir, I have added her. I'm guessing they should be able to log in.
अच्छा, हाँ, आता ते फक्त सुनील has joined. Professor Visser.
How big a crowd do we anticipate?
Yeah, a good crowd. It's all international crowd. And some people join here and some join on the YouTube also.
Oh, great.
Some join on here and the other people join on YouTube. It is live on YouTube.
So who was behind organizing all of this?
It is World Federation along with Indian Academy of Neurology. Chandrasekhar?
Yeah.
You is asking some question. Who is organizing? Please answer.
Yeah, this is tropical and geographical specialty, neurology specialty group of World Federation of Neurology. in collaboration with FINE. And,
Indian Academy of Neurology.
yeah.
Forum
Right,
of Indian
right,
Academy.
May you explain what is really fine?
Forum for Indian Neurologists Education.
Ah, okay.
Dr.
It's a-
Mehta, I'm sending
It's a
you the-
voluntary organization. It is a voluntary organization. It is basically headed by Sudhir Kothari and his group and many other volunteers. I am also one of the volunteers. And we present cases and we have the best of speakers from all over. And it's a fantastic program. And whatever is possible, we put on YouTube. Wherever the speaker has allowed us to put it on YouTube, we have done it. So it's a fantastic collection of lectures as well as cases, as well as quizzes and controversies and so on. In fact, if you have a chance, do open your YouTube and go to FINE and you can see the whole program there.
Yeah. Professor Visar has joined. Okay, good.
Hello,
Hello.
Metram.
Yeah,
Hello.
hello.
Hello. Hello, Gajre. Sunil, how are you?
Yeah, hello, good evening.
Good evening. Good evening. Good evening.
Pleasure to see you after a long time.
Yes, but I have seen you in the middle, some other teaching program.
Yes, right.
Good.
Fine.
Good.
And today being Teachers' Day in
Yes.
India,
Yes.
you have been our very first teachers in neurology,
Thank you.
1984 to 1987 when I was at NIMANS.
Yes, thank you.
Yeah.
For our foreign speakers, today it is a Teachers' Day in India.
Okay.
And this is the birthday of our first president of India, Dr.
see.
Radhakrishnan. And he rose to the president of country from a teacher in an institution. So how a teacher could raise up to the president of the country. So his birthday is being celebrated as a Teachers' Day.
Mhm.
So that is continued for, this is 122nd year birth centenary of Dr. Radhakrishnan.
Impressive.
Yes. So that's why Dr. Sunil Gajre is telling me, because he was with us at an institute in Bangalore in India.
Uh-huh.
Dr.
All
Mehta,
right.
should we open the room since we are at
Yeah,
since
you open the room
scheduled time.
and I think
And
Actually,
only Dr. Lakshmi Narsiman is the only one, yes, who is yet to join.
we want Professor Akri Oliveira.
Oh, okay, 1 minute.
Yeah. He's trying for last 20 minutes. And Professor Raj Shakir, you have a mail of Professor Raj Shakir. He's also trying to join in.
So for Dr. Raj Shakir, sir, I'll need his email ID, sir.
Acha, you have an email ID. I have already forwarded you, na? Because I am now on
Sir,
the laptop
right.
and I can't like send you the email ID right now.
Okay, let me see what I can do.
But Chandrasekhar, can we start? They can keep
Acha,
on joining.
just hold on, Sunil. There is some problem. People, there are some important people who are not yet joined.
Yeah, Professor Oliver has to join because he is to introduce, talk about something.
Actually, all links were sent for some technical for which I think the emails were deleted, because of which we are facing this issue. Otherwise, everybody would have been able to join.
There were some technical problems, so
So for Dr. Marco Medina, Dr. Oliveira, and Dr. Gilmar.
Marco Medina will not join. We want Professor Akari Oliveira.
Yes, yes. They will be able to join within 2 minutes. Yes, they can. They'll be able to join. I'll just check in the participants.
As soon as he joins, then we start.
Yes, doctor has joined. Dr. Oliveira has joined.
Yeah, I think he's joined. And
yes,
I'm
I'm here.
Shakir. Hello.
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 Good afternoon, Professor.
Yeah, good afternoon.
Good afternoon.
Nice to see you.
Oh, that's nice to see you again, too.
And good morning for you in Brazil.
Yes.
Yeah,
At this time it's morning here.
yeah.
It's almost 10:30 p.m. a.m.
It's 7 p.m. in India.
That's too late for me.
Yes.
Mansi, you can open the room and send Dr. Raj Shakir's mail.
Yes, I have opened the room. I'll just, sir, I'll send you the link of Dr. Raj Shakir.
Okay. Where is Gagandeep? Is not there. Professor Oliveira, you will share your computer, or we want you to project?
I can share with my computer if you want. You prefer?
Hello. Join करो.
Share screen को type करें.
अच्छा, ठीक.
Ashwin, internet connection is
Have you seen it?
stable लेता है.
Have you received
Yes.
the presentation?
Yeah.
Yes. Okay.
Professor Oliveira, don't share your screen right now. I will tell you when to share.
Okay. I think it's better.
Yeah.
Would you like to stop my my presentation?
You can stop sharing the screen and then.
Have you seen anything? Not.
I think Professor Raj Shakir has joined.
Yes, I'm muting. Yeah, I
Yeah,
was
good afternoon.
on YouTube. Hello, I've been promoted.
Okay. Okay, Mansi.
Yes, sir.
You can share the screen now. We can start the session. Dear friends, good morning, good afternoon, good evening, buenos dias, bonjour. On behalf of Tropical and Geographical Neurology Specialty Group of World Federation of Neurology and Forum for Indian Neurology Education, I welcome you all for this 8th and the last session in this series of WFN-FINE Neuro-Infection series. Warm welcome to today's speaker, Professor Joseph Berger, to the chairs, Professor Marianne D. Visser and Professor Jack Callis. Professor Visser she's Emeritus Professor of Neuromuscular Diseases at the University of Amsterdam, the Netherlands. After her neurology residency from Amsterdam, she did a fellowship from Mayo Clinic. She enjoys working for the organizations. She was Treasurer, Secretary General for European Academy of Neurology for 6-7 years. Then she was elected trustee for 2 terms of the World Federation of Neurology from 2002 to 2008. And she's again a co-opted trustee since July 2020. She was chair of the WFN nomination committee from 14 to 2018. She's an honorary member of Netherlands Neurological Society and Neurology Society of France. Welcome, Professor Mariam Visser. Other chair, we have Professor Jack Callis. He's a professor conventionnaire at the University of Strasbourg, France. He's a clinical neurologist at the University of Strasbourg, and later he moved into private practice. He's a founder of Spain's speaking club, Club de Neurologia de Environment. So he's very much interested in environment. That is his, that environment issue is very close to his heart. He was president of RISE, and he did organize 4 or 5 international meetings on environmental health. And he's a co-chair of Environmental Neurology Specialty Group of WFN. Welcome, Professor Jack Callis. We also have an invited panelist, Professor Satish Chandra, who is advisor and senior consultant in neurology at Apollo Institute of Neurosciences, Bangalore. He is honorary professor, University of Liverpool, UK. He is a former director, vice chancellor, and senior professor at Department of Neurology, National Institute of Mental Health and Neurosciences. And he is a past president of Indian Academy of Neurology, and he has a special interest in epilepsy, neuromuscular diseases, neuro-infection, including HIV. Welcome, Professor Satish Chandra. I also welcome case presenters, Dr. Neetu Ram Rakhiani, Dr. Sunil Gajre, Dr. Lakshmi Narsihan. On the panel, I also welcome Professor Akari Oliveira, Professor of Neurology, Federal University of Sao Paulo, Brazil. And we also have former president of World Federation of Neurology, Professor Raj Shakir, and Dr. Gagandeep. I welcome you all. Encouraged by the interest of everyone, we plan to start the series 2 from 26 September with more interesting topics, so that we cover the whole spectrum of neuroinfection diseases across the globe. We'll not have continuous sessions on every Saturday. We'll have some breaks in between because Saturday is a family day. Professor Hamilton Barrera, a very close friend, was a Secretary General of Tropical and Geographical Neurology Specialty Group of WFN. But we lost him. And during his this last session of the series, we would like to pay tributes to him. And I request Professor Akari to do the honors. I once again welcome you all and enjoy the sessions. Professor Akari to take over.
Have you seen the presentation?
Yeah.
Yes.
Okay.
Yes.
Thank you. Dear Professor Chandrasekhar Mishoran, good afternoon. Namaskar. Is right? Namaskar?
Yes.
That's right.
Correct.
Okay, thanks. I received your invitation with great honor, respect, and great responsibility. To talk about Professor Dr. Hamilton Antunes Barrera is very important in my life. 37 years ago, I had the great opportunity to work in a medical region named Xingu. Xingu National Park is one of the Brazilian indigenous reserves. It's located in the center of the country, in the Amazon region, that we have 15 different indigenous groups, each one with terms and language and the chief. The name of the chief, indigenous chief, is cacique. They organize and coordinate daily activity. He does not give orders, but expect him to be an example. He strives for his home to be abundant. Although he is firm in leading the leadership to be friendly, tolerant, serene, and generous. He's responsible for applying the defining punishments, resolving conflicts, defining war, and organizing the hunting. The most important of them is Aritana Iwalapiti, the highest indigenous authority in the Upper Xingu, true leader of our indigenous nations, famous all over the world, being all respected in Brazil and abroad. And about Hamilton Antunes Barrera, born in December 17, 1947, Professor Hamilton graduated in medicine from the Federal University of Paraná, 1972. He received a doctorate in neurology from the University of São Paulo, USP, and a postdoctoral degree from the Faculty of Medicine of Paris. He was a professor at the Department of Neuroscience and Behavioral Sciences, Ribeirão Preto Medical School in Brazil. He worked in the areas of neurology, neuromuscular diseases, peripheral neuropathies, neuroimmunology, peripheral nerve regeneration, and stem cell therapy. For 30 years, he dedicated himself to teaching, studying, and treating multiple sclerosis. He introduced the pulse therapy with high doses of corticosteroids to treat autoimmune neuropathies. He was a pioneer in nerve biopsy in Brazil, contributed a lot to the understanding of neuropathies in different diseases, diabetes, Guillain-Barré syndrome, CIDP, Chagas disease, and others. He was a great enthusiastic member of the Brazilian Academy of Neurology. Their behavior, equal to that of the great indigenous leaders, a true leader, much more than a boss. A boss has the authority to command and demand obedience from the members of the group because he often considers himself superior to them. Although a good leader points the direction for success, exercising discipline, patience, commitment, respect, and humility. A good leader departs first, arrives before. He sees what no one saw. He sees first their potential defects and work on them. He puts the person in place. We consider, though, that the main imprint he left on his former residents, like me, came from the example he set. He molded us into meticulous clinical neurologists and taught us to be committed to our daily work. In a single sentence, how could you define him? Good government is feared by the people, while good recommendations are loved by them. Every time he was in the center, a lot of people around him. November 14, 2018, Professor Hamilton Antunes Barreira passed away. Professor Hamilton, you are sorely missed. Muito obrigado, gracias, grazie, zudank, thank you, arigato, spasibo, tanyaval. In language of the Indians in Brazil, they say only for leaders of leaders. On a word, ikatu. It's very important. Professor Hamilton, ikatu. Namaste. Thank you very much for you. And for the invitation to at this day, important day for me. Thank you very much for this opportunity. Thank you, Professor.
Thank you so much, Professor Akari Oliveira. It was a great that you were here. You are here today, and you paid a very nice tribute to Professor Hamilton, very close friend. Thank you very much. Please stay for the session and interact.
Thank you. I will stay. I will stay with you.
Thank you very much.
Thank you for this invitation this time.
Now we move on, and I request Professor Mariam Devisa to introduce today's speaker, Professor Joseph Berger.
Thank you. It's a great honor to co-chair this meeting together with Professor Jacques Rijs. But before introducing the guest speaker, I'd like to congratulate Dr. Meshram on the splendid organization of these extremely well-attended webinars. It's clear that there is an unmet need of up-to-date knowledge on neuroinfections, and you facilitated that in an exemplary manner, Dr. Meshram. I'm sure that I speak on behalf of all of us attending this webinar. We are very grateful for that. Now I will introduce Professor Joseph Berger, who is Professor of Neurology and Associate Chief of the Multiple Sclerosis Division of the Department of Neurology at the University of Pennsylvania in Philadelphia. His neurology training took place at the University of Miami School of Medicine, and after his training, he was faculty at the same place, serving in both the departments of neurology and internal medicine for quite a number of years. From 1995 to 2013, Dr. Berger was the chair of the Department of Neurology at the University of Kentucky. Dr. Berger's research interests include PML, HIV/AIDS, multiple sclerosis, and other inflammatory disorders of the brain. He published more than 250 papers and wrote more than 100 book chapters. He is the recipient of several prestigious awards. Dr. Berger has also interest in international health and was one of the founding members of People to People, an organization for HIV/AIDS care and education in East Africa. Dr. Berger, the floor is yours.
Thank you very much. Thank all of you for the introduction and the invitation. And let me pull up my slides. Can everybody see them?
Yeah.
Terrific. So I'm tasked with discussing fungal meningitis. And what I've elected to do is to embed in this talk a number of patients that I've seen over the last several years that have had fungal meningitis to serve as illustrations. To refresh your memory, fungi are eukaryotic organisms, and they include yeast, molds, and mushrooms. They have a cell wall that contains chitin, which distinguishes them from plants, which have cellulose. And that cell wall is combined, the chitin is combined with glucans, which is quite different than the chitin that you find in insects. Many grow as single-celled yeast that reproduce by budding or binary fission, but most grow as hyphae, which are these cylindrical structures ranging in size from 2 to 10 micrometers in diameter. And some of them are dimorphic. That is, they can switch between yeast and hyphal forms. And many of the dimorphic fungi are pathogenic to man. All of the fungi have a common ancestor. There are at least 1.5 million fungal species, but only 70,000 of them have been formally described. And we know of only 300 that cause virulence in humans. Obviously, I won't have time to go through 300 fungi, but I'll tell you about those that appear to be the most common, at least in the United States. It may be a little different in other areas of the world. Of those that are virulent in human, about 10 to 15% affect the central nervous system. And for the most part, these fungi have worldwide distributions, though you will find certain fungi in areas that are not represented elsewhere. Some of these happen to be pigmented molds. You can classify the fungi into that affect humans into those that cause cutaneous disease, those that cause systemic and opportunistic infection, and those that cause systemic and opportunistic infection. These that cause superficial cutaneous disease, for the most part, are not ones that we as neurologists worry about and are extremely common. The tinea capitis and tinea pedis, or athlete's feet, the tinea versicolor due to Malassezia furfur. And then you have those that fall into these other phyla that do cause central nervous system disorders. If one looks at, and again, I apologize because I couldn't find good data, worldwide data, so I'm referring chiefly to US data, but the most common invasive mycoses in the United States is Candida. And I suspect that's probably true worldwide. So in the United States, there are 72 to 228 infections per million people annually of Candida. The second most common is Cryptococcus. The incidence here is 30 to 66 infections per million annually, and it is the most commonly recognized CNS infection. Now, I'd like to underline that it is the most commonly recognized because from pathologic studies, there's evidence that really Candida is more commonly observed at the time of autopsy than Cryptococcus is. And then Aspergillus, at least in the United States, is 12 to 34 infections per million annually. So this comes from aggregated health data in the United States, and it was collected in 2006, but it's not terribly different now. If one looks at the causes of meningitis requiring hospitalization, about half were due to viruses, 20% due to bacteria, 17% were unknown, but 7% were due to funguses. If you look at how frequently an invasive fungus causes central nervous system disease, you'll see that with Candida, the number is all over the place, between 3 and 64%. So it depends on how carefully one looks and the nature of the population that you're treating. And for invasive Aspergillus, it's 4 to 6%. For disseminated Cryptococcus, though, it's extraordinarily high. It's over 2/3. For histoplasma, 5 to 20%. Disseminated coccidiomycoses, we'll talk more about each of these, it's 25%. And for zygomycoses, 12%. Now, there are certain things that predispose you to fungal infections, and I'll go through some of these. Prematurity clearly increases the infant's risk of Candida. Inherited immune deficiencies generally increase your risk of Candida, Cryptococcus, and Aspergillus. Steroids increase your risk of Cryptococcus and Candida. The drug that we use for multiple sclerosis, fingolimod, an S1P receptor modulator, increases your risk of Cryptococcus. And my suspicion is that the other S1P receptor modulators will do the same. Cytotoxic agents will increase the risk of Aspergillus and Candida. HIV/AIDS, the most common fungal infection we see in that population is Cryptococcus, though you may see others. Alcoholism increases the risk of sporothrix. Iron chelators, IV drug abuse, and diabetic ketoacidosis are big risks for the zygomycetes. Trauma increases your risk of candida and the demataceous fungi, which are often contaminants at the time of surgery. And near drowning increases one's risk of pseudoaleresia. Now, you don't have to be immunocompetent or have some underlying reason to have a fungal meningitis. And it turns out that we will see cryptococcal meningitis, coccidiomycosis meningitis, and histoplasma meningitis in individuals who are otherwise perfectly healthy immunologically. If one looks at fungal meningitis and compares it to other forms of meningitis, in terms of the age of patients, there's an interesting observation, and that is that older people seem to be at an increased risk for the fungal meningitis relative to the other meningitis. And another interesting observation is that people who develop fungal meningitis relative to the others, bacterial, viral, and non-specific, tend to be in the lower socioeconomic groups. That's not to say that you're protected if you're not, but there is this disparity. So how does the fungus get into the central nervous system? And the bottom line is that it's poorly understood. But there are three mechanisms that predominate. One is transcellular migration, where the fungus goes directly through the endothelial cell into the brain. Another is paracellular, where it infiltrates between the endothelial cells and the astrocytes and gets into the brain. And the third is called the Trojan horse mechanism, where the organism is within a macrophage or a monocyte and gets transported into the brain. And all three may be in play with any particular fungus. So with Cryptococcus neoformans, we know that there is a direct transcytosis through endothelial cells, but it's also been demonstrated to cross with infected phagocytes, the so-called Trojan horse mechanism. And some believe that there's this paracellular infiltration as well. There are certain proteins that need to be expressed and activated in order for the transcellular transport to occur, and it's been identified with Cryptococcus. It's an activation of the protein kinase C-alpha. And individuals that have reduced immunity often have reduced blood-brain barrier permeability, and that too may increase their risk. Now, how the fungus presents within the central nervous system is very dependent on how it grows within the central nervous system. So if it grows as a true yeast, like Cryptococcus, histoplasma, blastomycosis, coccidiomycosis, the predominant pathology is that of meningitis. That's not to say you can't see abscesses and infarction, they occur, but it's predominantly a meningitis. Those that are pseudohyphae, in particular Candida, one finds microabscesses very commonly. And these microabscesses are so small as to not be seen on imaging studies. So it's at the time of pathology that one recognizes them. And therefore, we often end up treating patients who have Candida systemically for the suspicion that they have CNS Candida because of their clinical manifestations, not so much what it is we see in their imaging or their spinal fluid. They also have meningitis as well. Those that grow as true hyphae, either septate like the aspergillus or non-septate like mucor, typically cause infarcts. They also cause macroabscesses, but the thing we're most concerned about are infarcts. They tend to grow into and around veins and arteries and infarct the brain. So let's talk about true yeast. I'm going to present a case to you. In fact, I'm going to present several cases to you. This was a patient of mine, a 65-year-old woman who was status post-liver transplant for autoimmune hepatitis. And 5 to 6 weeks before she came to my attention, she had had headache and altered mental status. She had dramatic worsening 4 days before with stupor intervening. On examination, she had mild papilledema. She had a right third nerve palsy, fourth nerve palsy, sixth nerve palsy, a left sixth nerve palsy, and diffuse hyperreflexia. And the spinal fluid showed 40 cells, a protein of 200, a glucose of 10, a negative India ink, but the cryptococcal antigen was 1 to 2048. And this was her brain, and you see the leptomeningeal enhancement from the meningitis of Cryptococcus. Cryptococcus neoformans was first identified about 150 years ago, and the organism was isolated in 1894 and was described in a human tibial gumma in 1895. It wasn't until 1914 that meningitis from Cryptococcus was recognized, and it wasn't until 1956 that we had a treatment for it in the form of amphotericin. Now, if you go back into the older literature, you're going to see a large number of names have been used for Cryptococcus. So before it was called Cryptococcus neoformans, it was called Torulopsis. It's also been called European blastomycoses, saccharomycoses, and champignon, just mushroom in French. It is ubiquitous. So Cryptococcus neoformans is found worldwide. However, there are other variants such as Gadi, which is seen in Australia, Southeast Asia, Central Africa, and more recently it's been recognized with increasing prevalence in the west coast of the United States. It used to be thought just in California, but we're now seeing it in Oregon and in the state of Washington. Prior to the HIV epidemic, this was still a disease predominantly of men. So it was 3 men for every woman. And the age range, interestingly enough, was 30 to 50 years generally. So 2/3 of the patients were in that age range, and it did not affect any race predominantly. The associated disorders for Cryptococcus or AIDS in China right now, it remains the most common opportunistic infection. In the United States, it was never the most common opportunistic infection. It was always number 2 after toxoplasma. It's seen after organ transplant, steroid therapy, seen in leukemia and lymphomas, diabetes, cirrhosis, renal disease. It's seen with sarcoid and SLE. It's seen in patients with TB. So you can have 2 infections. There's an old dictum by Hickam: a man can have as many diseases as he damn well pleases. Something to keep in the back of your mind. It's seen with idiopathic CD4 lymphopenia, more recently seen with the S1P receptor modulators we use with MS. And you have to have a high index of suspicion when you have an MS patient on fingolimod or another S1P modulator who presents with an unexplained headache, because that's maybe all that they have. There are 2 varieties, as I mentioned, that have been distinguished. One is the neoformans, the other is the Gati. They're also divided into various capsular serotypes. It is the commonest recognized fungal infection of the CNS, and one acquires it by inhalation. And this organism is found in bird excreta, it's found in soil, it's found on fruits and on animals. There's an increased risk in dairy workers, and it can affect various organs within the body. It grows at 27 degrees, but not at high temperatures. It hydrolyzes urea. It's virulent in mice. And it has this mucinous capsule. It's the only encapsulated fungus that invades the central nervous system. And this is a picture of the capsule here. And you don't see it as well in this drawing. So as I mentioned, it's typically inhaled. It gets into the respiratory tract. Occasionally, it may initially infect the skin or the mucous membrane. You inhale spores. And the vast majority of people who develop this fungal infection through inhalation have little in the way of symptoms, so it's not recognized. And it then becomes a latent infection. And this is an important point because many of these, if not the majority of the fungal infections that we deal with, are actually opportunistic infections. They're organisms that we've acquired during the course of our lifetime. We've never fully eradicated them, and we live symbiotically with them, as we do, for instance, with JC virus, with herpes viruses like HSV1, VZV, cytomegalovirus, and so on and so forth. the organs that it generally involves are the respiratory system, where it can cause a coin lesion in the lungs, the lymph nodes, the skin, eyes, bone, and of course the central nervous system. So I just showed this to show that it generally survives in macrophages, gets it into the lungs, and from the lungs it disseminates into the brain. The initial infection, as I said, is generally inapparent, but it occasionally is a self-limited pneumonia that resolves over weeks to months. The patient complains of fever, pleuritic pain and cough, malaise, weight loss, and then recovers without any treatment and without anybody being aware of what the offending organism was. The properties that enable CNS infection include, most importantly, a receptor on cells in the central nervous system for a ligand in the yeast. In addition, you know, it has this capsule that sort of is protective in terms of cell-mediated immunity and macrophages destroying it. And it grows quite well at 37 degrees. It also expresses melanin, which is an antioxidant and may be protective for it. As I mentioned earlier, it is known to cross into the brain through transcellular migration, though other mechanisms are likely at play. It proliferates in the subarachnoid space. You then develop these focal granulomas of macrophages, lymphocytes, giant cells, and fungi, and it extends, the organisms extend along the Virchow-Robin spaces. And you develop these tubercles that measure 2 to 3 millimeters along the vessels. And in fact, the vessels may be so invested by this organism, as is true of many of the fungal infections, as well as others, that you can get infarcts, often involving lenticulostriate vessel perfused tissue. You can also get cryptococcomas, which generally occur within the hemispheres, although I just had a case where it was the cerebellar hemispheres that were chiefly involved. Headaches are seen in 87%, fever in 60%, nausea and vomiting and altered mental status, as well as meningeal signs in only 50% each. So a patient may just have a headache when they present with cryptococcal meningitis. That's not uncommon. Visual disturbances are seen in a third, and cranial nerve palsies in about a third. Papilledema is seen in a quarter, ataxia in about a quarter, seizures will intervene in 15%, aphasias in 10%, and 10% have absolutely no signs or symptoms at the time they have this disease. And we see that with some regularity in the AIDS patient who is harboring cryptococcus. It's not doing anything. They're not complaining of anything. You make the diagnosis of HIV. You start them on an antiretroviral therapy, and they develop immune reconstitution inflammatory syndrome to cryptococcus as their immune system recovers. And you first make the diagnosis of cryptococcal meningitis when you've started them on antiretroviral therapy. The CT scan and MRI are very often normal. The meningeal inflammation could be minimal. You'll see focal mass lesions, but they're fairly rare. These include cryptococcomas, which are indistinguishable from pyogenic abscesses, pseudocysts, which have this soap bubble appearance to them, and choroid plexus granulomas. And in some people, you will see strokes due to this perivascular infiltration, or even brain edema with herniation. I had a patient when I was a resident at the University of Miami who was probably the first HIV patient that I'd seen, although I say that speculatively because HIV hadn't been described at the time. And he had recurrent cryptococcal meningitis without any abnormalities in his brain. I would bring this up because he had recurrent spells of the cerebellar fits of Hewlings-Jackson. And I didn't know what they were, and the attendings that accompanied me in his care did not know what they were, in which he would periodically complain of a very severe headache. He developed very large pupils. He developed epistotonic posturing and this irregular breathing, the medullary biot's breathing. And it was due to impaction of the cerebellar tonsils from increased intracranial pressure. And then you would disimpact and he'd be fine. And he ultimately died from herniation. So this is one of those diseases that can cause something like that. Here are radiographic findings. You see the hyperintensity infiltrating the sulci, also contrast enhancement in the basal ganglia in a patient with cryptococcus. Here's leptomeningeal enhancement. It could be quite subtle. And then this is an AIDS patient. So this is an individual who developed iris from the heart treatment. And you see that the enhancement of the meninges is much more prominent. And they now have a lesion in the cerebellum that was virtually inapparent at the time that they were first seen. And this is another patient with cryptococcus where it's around the base of the brain and infiltrating along the middle cerebellar arteries. And here are these little cryptococcomas that one can see. You'll often see them in the basal ganglia or in the hemispheres. But as I mentioned, I had one recently in which it involved the cerebellum. Here's a patient with a lacunar infarct of the basal ganglia in association with cryptococcus. What do we see in the spinal fluid? 97% will have increased white cells. They're usually less than 800. The protein is typically less than 600, but elevated in 90%. Opening pressure is elevated in 64%. Hypoglycorrhea with glucoses between 15 and 35 and 55%. India Inc is positive in about a half. The cultures are positive in 75%, so 25% of individuals have negative CSF cultures. And by the way, it's important to culture the blood for the fungus as well, because they often have a fungemia, and that implies a poor prognosis. Cryptococcal antigen is positive in greater than 95%, and it's helpful to get an elevated beta-D glucan. This is a component of the fungal cell wall, and it doesn't tell you that you have cryptococcus. It simply says that you're likely to have a fungal meningitis if it's positive. The cryptococcal antigen is very helpful, but it may be unreliable. If you have systemic cryptococcal titers of greater than 1 to 8, it suggests disseminated disease. And the most common sites are the lung, the blood, the kidneys, and the bone marrow. And fungal blood cultures may also be positive. Now, there are many causes of hypoglycorrhea. I just put this up on the screen to refresh your memory that just because you see hypoglycorrhea doesn't mean you necessarily have an infection. The symptoms of cryptococcal meningitis in AIDS patients is a little different than those without AIDS. So what one sees.
patient था फिर वो contact करेंगे आपको कोई चलो.
So there's somebody talking. Could you mute your? Thank you. The India Inc is more often positive in AIDS patients. The antigen titers are more often higher in the spinal fluid. The white count in the spinal fluid is generally lower in the AIDS patient. And of course, the CD4 count is lower, and you're more often to see systemic disease. And that's expressed on this slide as well, where intracranial pressure and features consistent with a more advanced disease are generally seen in the AIDS population. If one looks at the histopathology of cryptococcus, 2/3 of them have meningitis or meningoencephalitis. 18% you'll see cyst, 8% cryptococcomas, 4% in encephalitis, and 2% in abscess. So this doesn't necessarily add up to 100% because there's overlap. And here you see sort of a soap bubble appearance in brain parenchyma of these cryptococcal lesions. Here it is infiltrating a blood vessel, and here's a budding yeast adjacent to the ventricle. Prognostic factors include increased opening pressure, positive India Inc, decreased white count in the spinal fluid, low glucoses in the spinal fluid, high cryptococcal antigens, positive blood culture, and the presence of cryptococcus at extraneural sites. About 1/3 of the patients will die from cryptococcus. It sometimes takes months before that mortality plateaus. And only about 50% of patients are alive and well. It's important to diagnose this disease, as is true of other infectious diseases of the central nervous system, very early. When you suspect the disease, look for the cryptococcal antigen in blood. Also, culture the blood, get a chest x-ray, do a CT scan or an MRI, evaluate them for intracranial mass lesions. And of course, in your lumbar puncture, don't forget to perform cryptococcal antigen cultures, beta-D-glucan. Once you diagnose them, the treatment is devised in 3 phases. So there's an induction phase of 2 weeks, a maintenance phase of 8 weeks on average. This varies from recommendation to recommendation. And then a much longer period in people that require secondary prophylaxis, like the AIDS patient or patients who have prolonged immunosuppression. So we generally begin with amphotericin and flucytosine, and then after 2 weeks, switch them over to fluconazole or itraconazole. And if they need to be maintained on something, they're generally maintained on fluconazole. And this is one of the treatment regimens. I show you this to tell you that electrolytes and renal function need to be carefully monitored when you're treating these patients. And it may be important in patient management to do a ventriculoperitoneal shunt because they can have elevated intracranial pressure, as that case I just mentioned to you. These drugs are not without complications. Amphotericin can be quite nephrotoxic. It can also be cardiotoxic and hepatotoxic and cause cytopenias. 5-flucytosine causes cytopenias and is also nephrotoxic. Fluconazole is generally pretty well tolerated. There is a hepatotoxicity that we see with it, and it can cause seizures. Okay, so that's Cryptococcus. Let me move on to another yeast. This was a 24-year-old woman in the horse industry. I lived, as was mentioned, for 20 years in Kentucky. So I saw a lot of people that worked in the thoroughbred industry. And she had presented in June 2004 with severe headaches and diplopia. She commented on having traveled to the Southwest United States. Whenever you hear that, you start thinking of coccidiomycosis. She, on examination, had papilledema in her right 6 nerve palsy. She had increased opening pressure. She had pleocytosis, a low glucose, and oligoclonal bands, as well as a slight elevation of protein. All microbiologic studies were negative at that time, and she was discharged from the hospital. She wasn't treated by us as a viral meningitis, and she recovered and did well. She actually moved to South Africa, where she took care of horses, and she did that for a period of about 4 years, and then returned to Kentucky. And when she returned to Kentucky, she had recurrence of the headaches associated with imbalance and visual problems. And this is when I first got to see her. At that time, she had papilledema. Her opening pressure was 25. She had an elevated protein in the spinal fluid. MRI, MRA, MRV were negative. And to make a long story short, she was extremely difficult to diagnose, but ultimately, CSF histoplasma complement fixation, both yeast and mycelial phases were elevated. And what she turned out to have was histoplasmosis that had been present for over 4 years. It had been present for over 4 years in her central nervous system and not caused problems. And this was such a remarkable case that I actually wrote it up with my infectious disease colleagues. She responded well to a combination of ambisome and voriconazole. And when I last saw her a couple of years after her presentation, she was doing quite well. So histoplasma is a disease that in the United States is endemic to a particular area, the Ohio River Valley, the Mississippi Valley, and the Appalachian Mountains. It's present in soil and in domestic and wild animals. We'll frequently find it on the coats of horses. It's generally an asymptomatic disease. You have a primary pulmonary infection like Cryptococcus. It gets into the reticular endothelial system. It sits there forever and ever and ever and never causes any problems. It is a disease that is increased in frequency in our HIV population. Now, when it is initially acquired, symptoms generally develop 3 to 17 days after you're exposed. You develop fever, chest pains, weight loss, dry cough, headache, sweats, chills, fatigue, hemoptysis, and night sweats, and then it goes away. And it'll go away in the absence of treatment. And this is a case of disseminated pulmonary histoplasmosis, what it can look like. And I can tell you that when you do chest x-rays of people in the state of Kentucky, I would say that it's not that uncommon to see a chest x-ray with features just like this, that is residual disease from their histoplasma. They had no idea they ever had histoplasma. It generally disseminates in the setting of immunosuppression, though you do not need to be immunosuppressed, and the woman that I presented to you was not immunosuppressed. CNS disease occurs in 10 to 25% that have dissemination, and generally it causes a basilar meningitis, but can cause intracranial mass lesions. And the CNS disease may occur many years after an apparent cure, and culture negative biopsies of the lung may be mistaken for sarcoidosis. Patients with this disease have headache and confusion and altered mental status, cranial neuropathies, seizures, personality change, and focal features are seen in 10%, and meningismus, or signs of meningeal irritation, in about 10%. In about a third, the chest x-ray is normal. So in 2/3, you'll see abnormalities on the chest x-ray that may suggest to you that the patient's had histoplasma. The CSF shows a monocytic pleocytosis with increased protein and decreased glucose, but occasionally you'll see a neutrophilic pleocytosis, and that can be confusing. Positive CSF cultures are only present about 50% of the time, and blood cultures are positive about 50% of the time. And bone marrow cultures can be positive as well. Serum and CSF histoplasma antigen is a very specific test. You should look at the urine and you should look at the blood as well as the spinal fluid. To treat this disease, you need to use amphotericin. We use now, of course, as I showed in that last patient, ambisome, because this decreases the risk of the renal toxicity we see with amphotericin. Itraconazole is also used. This is a drug that requires frequent checks of liver function, and also serum levels need to be assessed periodically. And this is an organism that you don't want to use fluconazole in because the organism develops resistance. Another yeast that grows within the central nervous system is coccidiomycosis. And this is a dimorphic yeast that we see in the United States in the San Joaquin Valley out in California and in Arizona. It's found in the soil, it's inhaled in the lungs, and dissemination generally is confined to those people that are immunodeficient, though on occasion it can occur in the absence of an immunodeficient state, that is a CNS infection. So pregnancy and diabetes are big risk factors. We'll see it in HIV, and for reasons that remain unexplained, but probably have to do with immunogenetic factors, we see it more commonly in our African Americans and in our Hispanic population. And this is what the organism looks like. This is what it looks like in culture. And there's 6 main presentations. So there's an asymptomatic form, which is the most common. There's a pulmonary form. There's skin infection, as we see here, soft tissue infection, skeletal infection, and of course, meningitis, which is what we're most concerned about. Features of severe infection include loss of body weight, intense night sweating, infiltrates of greater than 50% of one lung, the presence of anticoccoidal complement fixing antibody titers that are greater than 1 to 116, dermal hypersensitivity, and symptoms that persist for more than 2 months. If you look at people that have died with coccidioides, they have more than just meningitis. So those dying will have not only meningitis, but a cerebritis as well, and on occasion, these scattered miliary granulomas throughout the brain. In the average patient who doesn't die, who has this disease, the brain imaging is frequently normal or simply shows meningitis, meningeal enhancement. Eosinophils are one of the features of this disease, although there's seldom a very large number of eosinophils in the spinal fluid, but some degree of eosinophils is seen in about 2/3. And you make this diagnosis with cultures and with complement fixation tests. Again, the treatment similar, ambisome, fluconazole. They're the two that are most frequently used. Itraconazole is equally effective, but has poor CSF penetration. And voriconazole is another effective medication. Now, I've never seen actinomycosis. I just throw this in here. I'm sure some of the people on this webinar have seen it. It's most often a skin infection, but I'm told that, and I've read that CNS infections can occur with actinomycosis. Pseudoallergia, which I mentioned, is something that you worry about in people that have been in near drownings. It's also seen in transplant patients, and this was a case seen in a transplant patient. Blastomycosis we do see, at least in the United States. It's probably more common here than anywhere else, but it still remains a fairly uncommon infection, more often in men than in women. It's transmitted by inhalation from decomposing vegetation and rotting wood. And it's usually an indolent disease with chronic progression, with skin lesions in exposed areas, but also chest X-ray abnormalities with nodular infiltration. It's an uncommon cause of meningitis, but it can cause vertebral osteomyelitis. And again, the treatment is with amphotericin and voriconazole. And then sporotrichosis is a fungus found worldwide, again, in soil, moss, on rose thorns. There was a very interesting case in the New England Journal of a woman who got a rose thorn when she was doing her gardening in the skin about her eye, and ended up developing sporotrichosis in a periocular distribution. It's typically a chronic skin infection. It can be cutaneous, pulmonary, or disseminated, and when disseminated can involve the central nervous system. There are only 15 cases of CNS sporotrichosis in the literature as of 1987. I don't think it's changed all that much. Now, what about the true hyphae? So this is an interesting patient. This patient, if I recall correctly, was somebody who was presented to me he was a patient in Jordan. And I had a collaboration when I was at the University of Kentucky with King Abdullah Hospital in Irbid, Jordan. And they had presented this patient to me, and I said, I think this patient has mucormycosis. And they said, we'd never heard of mucormycosis. And indeed, he turned out to have it. So he's a 50-year-old man with diabetes and hypertension. He had severe headache and fever. He had migratory skin rashes and swollen salivary glands, develops bilateral ptosis, bilateral fifth nerve palsies, an inability to close his mouth, facial diplegia, a deviation of the uvula, and absent gag with high sed rate and C-reactive protein, and a pleocytosis of 20,000. This was his CT, or his MRI, I guess. And it shows that he has maxillary sinusitis. They ultimately do a biopsy. They demonstrate that he has mucormycosis. He's treated with amphotericin. And it's interesting because I said, you're going to have to do an extensive exenteration in order to remove the fungus. And I explained that to the family. There was an interpreter explaining it in Arabic because I saw him on more than one occasion. And they said, no, we're not doing that. And to make it, he ended up doing fine without the extensive exenteration. So he's a very unusual case, I think. They start him on amphotericin. He has this purulent discharge from his palate. He does develop blindness because of increased intracranial pressure, and ultimately capsofungin is added. So these mucormycoses include rhizopus, mucor, absidia. They're ubiquitous in bread and fruit mold, soil, and manure. They were first described causing brain abscesses in 1885, and they're the most aggressive of fungal infections. They have a worldwide distribution, all ages, and there's a triad that you should keep in the back of your mind: diabetic ketoacidosis, nasal orbital necrotizing infections, the Black and Nares, and meningoencephalitis. 95% of these people are immunocompromised. Most have diabetes, but you'll see it with hematologic malignancy, renal transplant, intravenous drug use, and with the use of desferoxamine. The hyphae invade arterial walls. They also invade venous walls. They spread into the brain, and they clot these arteries, and you end up with the hemorrhagic infarctions. Among the more common presentations is cavernous sinus thrombosis, and this is what the hyphae looks like growing within the tissue. The symptoms include facial pain, diplopia, lacrimation, nasal stuffiness, discharge, fever, and lethargy. If you look carefully at them, you'll see nasal ulcers, nasal discharge. There'll be facial swelling, cranial nerve palsies with ophthalmoplegia, focal deficits, and seizures. And on X-ray, you'll see bony erosion, sinus opacification. And of the abscesses, the frontal lobes and the basal ganglia are the most common sites that one sees involved. The basal ganglia in particular for the abscesses. The spinal fluid findings are non-specific, and I can't tell you how many times I've had to twist the arm of the otolaryngologist to do a blind biopsy in a patient who has cranial nerve palsies and diabetes, diabetic ketoacidosis, that is otherwise unexplained. Because they'll look in there and they won't see anything, and they'll say, well, I don't see anything. I don't see anything to biopsy. Well, tell them just to go ahead and biopsy the damn thing, because very often you'll find the organism on the biopsy in the absence of there being anything seen grossly. And this is what may be seen grossly. So these necrotic lesions, and then the chemosis and conjunctival infiltration. It is a terrible disease to have. The morbidity and mortality prior to amphotericin was virtually 100%. Nowadays, it's still very high. So with diabetes, it's still greater than 70%. With other risk factors, it's about 20%. And about 70% have residual defects. It's important to correct the metabolic abnormality. So in the diabetic patient, not only is it important to treat them with the antifungal compounds, but it is important to correct the metabolic abnormalities, because the hyperglycemia impairs the phagocyte's ability to eliminate the fungus. I still recommend exenteration of infected tissues, although it can be extremely crippling and disfiguring. And amphotericin B, there's some data to suggest hyperbaric oxygen is helpful. So here's another case that I've seen. 36-year-old man had AML. He was in remission after a stem cell transplantation in February of 2018. He was on Cytoxin in February of 2019. He was on mycophenolate mofetil in March of 2019, and tacrolimus was continued through August of 2019. He had no recent neutropenia. He develops graft versus host disease of gut and liver, for which he's admitted to the hospital. And he's again started on steroids, MMF and Jakafi. And he is treated prophylactically with caspofungin, Bactrim, and acyclovir. And on January 5th, 2020, he loses vision in the right visual field. And this was the lesion that was observed. So ring-enhancing lesion in the left occipital lobe. And this was biopsied and demonstrated to be aspergillus. He had an MRI of his head that was negative, chest X-ray was negative, chest CT was negative, blood cultures were negative. Spinal fluid was really negative. I mean, the values were, there was nothing there. And we had a result to brain biopsy, which showed, as is seen here, the aspergillus. Aspergillum refers to the appearance of the fungus. It's said to appear like the aspergillum that the priest uses to sprinkle holy water. It was first described in a sphenoid lesion that had spread to the optic chiasm and internal carotid artery in 1897. It is ubiquitous, like most of these fungi, present in soil, but also in organic debris and water. There are at least 9 aspergillus species that cause CNS infections. It has a worldwide distribution and no sex or age predilection. You're at risk with neutropenia, hematologic malignancies, and post-transplant with diabetes, sarcoid, and TB. Pathology includes vasculitis and infarcts, cerebritis and abscess, and granulomas are rare. The lung, as with all these, is the primary site of infection. There are two patterns of CNS infection. One is a direct extension from your nasal sinuses, paranasal sinuses. The other is a hematologic dissemination from the lung. And stroke is the most common manifestation. Again, it has a predilection to grow in and around blood vessels. All the serologic studies for aspergillus to date are experimental. And the treatment is extirpation and drainage and amphoterasin. Here's a large MCA, hemorrhagic infarction, consequent to aspergillus, and here's a picture of one at autopsy. So we had a problem in the United States, which was unique, but I draw this to your attention because it can occur anywhere. These were fungal infections associated with injections of contaminated methylprednisolone. And the methylprednisolone was being compounded at one center in New England called the New England Compounding Center. And they were preparing these drugs for individuals that it was not regulated. Our compounding pharmacies are not regulated, or at that time, were not regulated by the Food and Drug Administration. And they had this aggressive business selling preservative-free methylprednisolone that people would then use for epidural injections. And there were 14,000 people exposed to this, compounded steroid. 11,000 of them received spinal or paraspinal injections. As of March 2013, 720 cases of fungal disease have been described in 48 and included 48 deaths in 20 states. And you see the distribution here. Now, it turned out to be a most unusual fungus, not one that we associated with CNS disease before. It was Encephalitis rostratum, seen in this picture on the right side. It's a soil and plant mold that had contaminated the compounded steroids. It was difficult to culture out. It was identified in sealed bottles of the preservative-free methylprednisolone. The index case was identified as aspergillus, but it turns out that most of the cases were Encephalitis rostratum, but other fungal species were identified in these batches. And it caused a variety of clinical symptoms. So we saw meningitis, we saw stroke, arachnoiditis, and even joint disease. And this was the subject of many articles. One of the best was in the New England Journal in 2012. So these people that developed meningitis had a neutrophilic leukocytosis very often with increased protein, but marginally elevated proteins, I mean, non-astronomical, and usually a glucose that was marginally low. And what one saw at pathologically was this perivascular infiltration and vascular infiltration resulting in a necrotizing suppurative vasculitis. Culture was very difficult. PCR was, and to the best of my knowledge, still remains experimental. So he made the diagnosis by tissue biopsy and the appropriate stains. DNA sequencing performed at our CDC identified the isolates. And this was clearly a case where beta-D-glucan assays would be helpful because you'd know that you were dealing with a fungal infection. You might not know what fungus, but you know the fungal infection. Pseudohyphae, so this is Candida. Now, I said earlier, Candida is just so common. I mean, we have these people that are neutropenic on their chemotherapy regimens, and they are sick as can be, and you go in to examine them as a neurologist, you're asked by the attending hematologist to see them, and what you find is that they're confused. They're encephalopathic, but their brain MRI doesn't show anything, their CT scan doesn't show anything, and their spinal fluid findings are just marginally abnormal. I apologize for the noise. My wife is cooking and set off the smoke alarm. So the Candida species we generally see is albicans. Albicans we all have. It's on our skin, it's in our gut, it's on our genitalia. And this is a fungus that generally is seen when neutrophil function is not normal. At autopsy, it is the most common fungal brain disease. And what one typically sees, as I mentioned earlier, these microabscesses that you can hardly see on MRI, unless you probably have a 7 Tesla or 10 Tesla or 9 Tesla, very high field strength unit. You may see full-sized abscesses in about 14%, meningitis in about 15%, and rarely vascular problems. So the clinical manifestations are quite nonspecific: confusion, drowsiness, stupor, fever. You have to have a high index of suspicion when you're going to diagnose Candida. Meningitis, meningitic features can be seen, and focal findings on occasion when you have these abscesses. These people are generally very ill and are on IV antibiotics for other infectious disease. As I said, the CSF is nonspecific, and you'll find the Candida at other sites. So where do you find the Candida? You take the catheter out of the patient, you know, the intravenous catheter, you culture it, and you say, oh my God, the damn thing's loaded with Candida. And that's where you make your diagnosis, and you say, we better treat him with amphotericin. And this is what it looks like in the brain. You could also develop a severe vitritis. And one of the things that I found quite helpful is when I am confused about what's going on with a patient, it is often helpful to get the ophthalmologist in there to get a good look at the brain, at the eye. Because the eye, after all, is just an extension of the brain.
Dr. Berger, sorry to interrupt you, but do you have many remaining slides?
No, not many. I'm just about finished.
Oh, wonderful. Thank you. Yeah, sorry for the
Okay.
interruption. Yeah.
That's fine. I knew it's a big topic.
Yeah, I know.
So cladosporum, I won't say much about. We don't see it too often. It's usually a slowly developing CNS mass, and you make the diagnosis by biopsy. And I'll say sometimes fungal infections are obvious, as in this case. So I'll stop my sharing there and take whatever questions you have. Thank you very much.
Thank you very much, Dr. Berger, for a brilliant lecture and for sharing those impressive cases with us, all from your clinical practice. I wonder there, I see some questions in the questions and answer area, and they're all from one neurologist, Dr. Narayan. And I wonder, for the sake of time, whether it's possible that you exchange the questions and answers by email.
Yeah, I'd be happy to do that. That's not a
Wonderful.
problem.
Once again, thank you very much.
Sure,
and I give
thank
the
you,
floor
Dr.
to
Professor.
Dr. Meshram.
Yeah, we can have comments from Professor Satish Chandra, Dr. Raj Shakir, or Professor Oliveira. Any comments, Dr. Satish Chandra?
You're muted, Dr. Satish Chandra.
Yeah, your mic is, Mansi, can you unmute Dr. Satish Chandra?
Yes, I'm
Yes.
just trying to do that.
Yes, it was a brilliant. Yes, thank you. Thank you. It is a very brilliant lecture by Professor Joe Berger. And we see in India much more of Candida, more than the Candida is cryptococcal meningitis. And we see with both immunocompetent and also in immunodeficient individuals. We had a large series of cryptococcal meningitis. One of the things which we observed was very severe headache as the manifestation. So much so, as we see tuberculous meningitis here, pyogenic bacterial meningitis, this was one of the differentiating points. We wrote it up saying that it is an extremely severe headache, which gives a clue. And that headache doesn't go till the meningitis settles down, may even take about 2 weeks or so. So have you seen this type of unbearable, severe headache as a manifestation of cryptococcal meningitis in your experience? That is number one question. And the second comment, I quickly make it, is the ophthalmological involvement in cryptococcal meningitis, similar to almost like tuberculous meningitis in the form of maybe cryptococcoma, as well as like a tuberculoma inside, and also optic nerve involvement with demyelination and axonal involvement. But both were seen and we have reported that. So any comment from your side? Thank you.
So I share your opinion that these headaches can be extremely severe, probably worse than any other, and difficult to treat until the meningitis is treated. So I've observed that as well. I must say that I don't recall seeing anybody with, other than papilledema, maybe the optic nerve atrophy that occurs following the papilledema. I don't recall seeing anybody with cryptococcus within the eye itself or within the retina, but I'm aware that it occurs. I just personally haven't seen it.
Thank you.
Any comments from Professor Jack or Dr. Raj Shakir?
Yes, I was very impressed by your talk, Professor Berger. I think I have to point to what you said at last, that Candida belong to the normal flora. It's the first fact. It means that all the other fungus are not usual. We are not usually carrying this other type of fungus. And when we are exposed to this one, if we have a risk factor, we may become ill. Is it correct?
Well, I think that the frequency with which we are exposed to these other fungi varies from what you do and where you live. So I'm almost certain that I've been exposed to histoplasma and cryptococcus, and I'm just living symbiotically with it. And I think so I'll give you an example. Toxoplasma, for instance, if you look serologically at people to see whether or not they have toxoplasma, in the mountains states of the United States, it's 9%. In New York, it's 50%. But in your country, it's 80 or 90% of people have had exposure to toxoplasma. Now, you're not going to develop CNS toxoplasma until you develop some immune compromise. It is true, though, that Candida is present in all of us, and that's not true of the other fungi.
Okay, this is a very important point, because one of the questions was if we are exposed to this when we are tourists, for example, in the Pacific coast in the US, will we become ill if exposed to any, and even if we are immunocompetent or not. And this it's why it's I think it's an important point to say, when you are exposed, exposure does not mean being ill. It's very important to point to this, because you have underlined all these risk factors, which in general are decreasing the immune response, and the immune response seems to be the crucial fact for any resistance or defense against fungal infection. Is this correct?
That is correct. That by and large, there has to be some sort of immune abnormality. We live symbiotically with all these fungi. We live symbiotically with a lot of pathogens. Yeah. And it is the impairment of your immune system that gives rise to clinically significant disease.
I wrote also another question about the climate change effect on the occurrence of some of fungal infection. And I read an article, or I was aware of what happened in the Pacific West Coast in the Vancouver Island, with an increase of exposure and illness related to Cryptococcus gatti. May you comment about this?
Well, only insofar as I know what you know, that we're seeing this clearly more often. There is some evidence that it may be related to climate change. We did not. I think the belief is that that this was not an organism seen in the northwest of the United States until the changes in the climate and its transmission from other sites from Southeast Asia, and then its population of the of the environment because it's really an environmental fungus. So there's probably some truth to it, but the jury's still out as far as I'm concerned.
Thank you much.
Okay, thank you, Professor Joe Berger, for an excellent talk. And
My pleasure.
Yeah, please stay on, and we move on to the
Well,
cases now. And we'll have some discussion later after the cases. Yeah, Professor Satish Chandra.
I'll unmute. Yeah, now I invite Neetu Ramarakini to present her interesting case of a stroke. And Neetu is there. Have you shared the slide with people?
Yeah, just a moment.
Yeah. Can you start now without wasting time, because we are short of time now? Yeah, please go ahead. Are you sharing, or Manasi is sharing?
Yeah,
Ma'am, do you need help sharing?
Yeah, I'll just go and start the slideshow. Just tell me whether I'm visible or not.
Not yet. So Manasi,
am I audible and visible?
You're audible.
You're audible,
Yes.
but your slides are not seen.
Slides are not seen. So Manasi, can you help her?
Yes, sir.
You can share the slide if you have.
Just a moment. So just a moment. So I'll start from the beginning. Are my slides visible now?
No,
your slides are not visible.
I'm on the Zoom meeting. You will have to go to the green button, share screen.
I've already done that. Just a moment.
And ma'am, you will have to select and then again click the blue button, share. Any videos do you have in your presentation?
No, I don't have any videos.
Okay.
Mansi, if you have slides, can you start?
Sir,
This is saying start your video. So would that work?
Yes, you will have to start video.
Okay.
It is only to start your video, ma'am, so that we can see you.
Yeah, that is for you.
To share the screen. To share the screen, and you will have to click the green button.
Is my slide? Yeah. Just a moment here. To get it. So can the second person start? If
I think.
I don't know. I don't know what is. Just let me try one last time.
If you want, I can start. If you want, I can start.
Share. I'll just go back to the share screen. Okay. And just let me see why it's not coming up.
Yes, we can see your screen, ma'am.
You can see my screen. Okay.
Yeah.
Now let me go to the PowerPoint.
Yes.
Okay. Now I go to the slideshow view.
Yeah, slideshow. Yes.
Yeah, and from the beginning. Okay, fine. So are my slides visible and am I audible?
Yes.
Yes, you are audible and the slides are visible too, ma'am.
Okay, yeah. So good evening and good morning, everybody. First of all, my greetings for Teachers' Day today. So I'll be discussing an unusual cause of stroke. So this patient, he is a 52-year-old male who's a businessman living in Jaipur, which is an urban area in Jaipur, and he presented with low back pain radiating to the right lower limb, associated with constitutional features like low-grade fever, weight loss, and decreased appetite of a subacute duration of 2 to 3 months. Onset was insidious, pain was progressively worsening, would get worse with activity. At this point, he had no headache, vomiting, bladder bowel, skin lesions. He was married, heterosexual, and no history of drug or substance abuse. He had history of intake of alcohol, which he had stopped 1 year back. His past medical history was unremarkable. He was not a smoker, no allergies. immunized, non-diabetic, hypertensive, so no chronic diseases in the past, and nothing significant in the family history. Some of these findings were from the notes of the doctor who had examined him at that point. So higher mental functions were normal. He was afebrile, cranial nerves were normal. So the only positive finding at that point was that his SLR was positive, 60 degree, and there was some diffuse local tenderness in the lower lumbar spine. He did not have any spinal gibbous or deformity. MRI was done. This MRI revealed T2-weighted hypointensities in T1, mildly iso to hyperintense on T2 at L5-S1 level, and enhancement on post-contrast. And we could see some enhancement on the, I'm not sure, is my cursor visible? So there was some enhancement and abscess in the source muscle. His blood investigations revealed mild anemia, a raised ESR of 57 millimeters in the first hour, a raised C-reactive protein, normal sugars, normal renal and liver function test, X-ray which was normal, echocardiography which was normal. He was advised biopsy of the lesion, but since he was not too keen, he was started on anti-tubercular therapy. The 4-drug standard anti-tubercular therapy was started on to him with isoniazid, rifampicin, paracetamide, and ethambutol. 10 days later, he came back with multiple episodes of vomiting and one episode of seizure with alteration in sensorium. He was drowsy, easily arousable. A contrast MRI brain done at this stage was normal. The positive clinical findings at this stage was mild neck stiffness and a low sodium. Because of the neck stiffness and because of his drowsy state, lumbar puncture was done, which revealed 340 cells, predominantly lymphocytes, with a low sugar, high protein, and the gram-QH culture were negative. No abnormal cells were seen. TB-PCR was negative. India Inc. was negative, and VDRL was negative. His other investigations revealed a microcytic pattern anemia. His initial counts at time of admission were normal, but later he developed a decrease in counts. He had hyponatremia with high urinary sodium. Again, he had normal liver function, kidney function test. Protein electrophoresis was ordered, which was normal. Ultrasonography revealed mild hepatosplenomegaly. A contrast enhanced CT of the chest was done, which revealed no evidence suggestive of tuberculosis, sarcoidosis, or fungal infection. Echo was normal. Blood, urine, and CSF cultures were sterile. So the treatment which was offered to him at this stage with the presumptive diagnosis of tubercular meningitis were standard 4-drug anti-tubercular therapy, that is isoniazid, rifampicin, paracetamide, and ethambutol with streptomycin. Steroids were added in view of the meningitis and very high proteins in the CSF. Sodium valproate and phenytoin were used as the initial anti-epileptic medication, but when dip in counts was observed, he was shifted to levetiracetam. Mannitol, pantoprazole was added, and ceftriaxone and vancomycin were also added because of the low CSF sugar. A repeat CSF done at a week's interval revealed some improvement in the CSF parameters. The blood sugar, the CSF sugar improved from 9 to 27. Proteins, the total counts decreased from 340 to 255. TB-PCR was negative. This time, again, fungal cultures and cryptococcal antigen was done, which was negative. He had gradual improvement in sensorium and could be shifted out from the ICU. A discharge was being planned, and at that point, he developed ptosis in the left eye with a dilated pupil. At this point, his MRI showed basilar exudates, which you can see here. So the MRI sequences which are showing basilar exudates. Ceftriaxone and vancomycin were continued for 14 days. So he was because of certain problems, he was sent back home with an advice, and he continued with the ceftriaxone and vancomycin along with anti-tuberculous and steroids. 20 days later, he was readmitted with sudden onset of vomiting, alteration in sensorium, followed by one episode of seizure. A repeat NCCT brain revealed bleeding in the prepontine area in addition to the exudates we were seeing earlier. A CT angiography was done, which revealed a dysplastic aneurysm arising from the basilar artery with origin in the left superior cerebellar artery. A DSA was planned by our neurosurgical team, and after discussion with the family, in view of the bleeding of the aneurysm, patient was Hessenheim grade 2, so a coiling of the aneurysm was done. This coiling was done with a flow diverter. Patient, however, deteriorated. He had fresh infarcts on the MRI, was ventilated due to poor GCS, and tracheostomy was done. A bone marrow and a biopsy was planned, but consent was not given by the family. So a brief discussion of the clinical course. A 52-year-old, otherwise immunocompetent, non-diabetic, no chronic diseases, presented with lumbar spondylodiscitis with paraspinal abscess, started on 4-drug anti-tubercular therapy, soon develops vomiting, hyponatremia, meningitis. Because of the low CSF sugar, antibiotics were added with steroids, clinically improved, then developed a cranial nerve palsy with pupillary involvement on the left side, it's the mistype. Then within a few days developed a prepontine bleed, subarachnoid hemorrhage because of the basilar aneurysm. The key findings were normal CECT chest for any evidence of tuberculosis, sarcoidosis, or fungus, ACE levels which were normal, blood cultures which were repeated thrice, which was sterile, and FNSS-FINE was done, which was inconclusive. A biopsy could not be done from the spinal lesion. And later he went on to develop the vasculitic infarcts we are seeing here. So to summarize, we were uncertain of what we were dealing with, whether it was tuberculosis, whether the drug was not going properly, or whether it was a multi-drug resistant tuberculosis, whether it was a fungal meningitis, whether it was a malignancy, a partially treated bacterial meningitis, or any other. Here I would like to invite the opinion of the panelist.
What you said was looks like a chronic meningitis, and what type of meningitis is the question. And as you rightly pointed out, you initially started the treatment with tuberculosis, because of its commonality in this country. However, what you mentioned was a bleed in the brainstem and possibly discoid aneurysm in the peripheral small vessels in the periphery. That type of aneurysm, which described as a mycotic aneurysm, doesn't occur usually with tuberculosis. So it is very, very uncommon. So we need to think in terms of a fungal meningitis, most probably a fungal meningitis with an aneurysm with a bleed which can occur with a mycotic aneurysm there. That is a possibility. Other alternative could be pyogenic meningitis with a subacute bacterial endocarditis with an aneurysm which has led to the bleeding in the pontine region. These are the two alternatives we can think about it and to investigate further with this way. That was the only way I can suggest that.
Any other comments?
Anybody else? Any other comments, or you, because of the shortage of the time, you can go.
What about the lesion in the spine? That doesn't fit into the fungus problem.
That if it is a pyogenic, then it could be a pyogenic, bacterial, which can go on to an abscess formation there, and on the bacterial meningitis with possibly, as you know, the aneurysm, mycotic aneurysm can occur as complications of that.
Professor Raj Shakir would like to make some comments.
Thank you. No, it is, as it was said, TB. Now, one comment was made, which I don't, why was just the antibiotics added because a low sugar? TB causes a low sugar. Why did you think you gave him what we call shotgun therapy, everything? Why was that done?
Tubercular meningitis very frequently, and sugars as low as 7 and 9 are not common.
Yes.
Seen.
Yes.
So the such low sugars we normally see only when there is fungus or there is some underlying malignancy happening. Also, bacterial meningitis can cause these low sugars. The patient was on anti-tubercular therapy when he reported to us. Despite being on anti-tubercular therapy, he was progressively worsening and going down. So just because the CSF sugars were very low and it was very alarming. So that is the reason ceftriaxone and vancomycin.
Thank you. One more question.
Was added.
The
also, in view of considering the possibility.
Sorry, in spite of the presence of inflammation in the lumbar region and this paraspinal we presume inflammatory, we don't know what it is. A lumbar puncture was done. People thought, wasn't there involvement of L5 and S1 on the MRI, the disc space or the body of the vertebra? Do you think that's TB as well?
Tuberculosis is endemic in our country, and that's the reason anti-tubercular therapy was started right away, looking into the picture of the patient.
Thank you.
But as I said, such low CSF sugars are fairly uncommon.
Very, very uncommon. Very uncommon.
I think for the sake of time, we have to. Sorry.
Yeah, I think Joseph Berger wanted to say anything.
Well, I was just going to say that as one unifying diagnosis, I still like tuberculosis. I mean, it would explain the abscess. It would explain virtually everything. And although it's extremely rare, I do think you could see intracranial hemorrhage with tuberculosis. It seems to me that I've seen it. So I would say TB is at the top of my list. But it could be any of these others.
Thank you. I think you should go ahead because short of time.
So we continued with anti-tubercular therapy and with antibiotics. Yes, it was a shotgun approach, but we were very worried about the low CSF sugar. However, we had sent certain reports which came out later. So what we found was a positive Brucella IgM and IgG, a positive Brucella agglutination test, and later from a research lab we could manage anti-Brucella antibodies in the CSF. So we questioned the family again. Brucella was not actually very high on the differential diagnosis initially, but because this gentleman was from an urban area, there were no pets at home, nothing else was there. But once this report came positive, we talked to the family, and then they said that yes, he was what in India they call as a jagirdar. So he had a country house, and he was very fond of drinking raw milk. So we got this history of drinking of raw milk. In fact, there was quarrel in the family if the wife would give him milk which was boiled. So after we got these reports, and then we had a consistent history also, we put him on specific anti-Brucella therapy. Ceftriaxone was continued, doxycycline was added, and rifampicin dosage was increased to 900 milligram as per brucellosis guideline. Prasugrel was added on the recommendation of the interventional team. He had cerebellar infarct. So these are the serial CSF reports. So he was managed with the help of the ID team also. So what we found was, just a second, yeah. So what we found was with specific anti-brucella therapy, the proteins kept going down. Are you able to see the dates? Yeah.
Yeah.
Yeah. So, and the sugar was improving, and the cell count from a cell count of 340 came down to 0.1 on 2008 to 0.19. The ADA was positive, which we later checked the literature. The ADA can be positive even in brucellosis. Just a very, very brief summary. Brucellosis can occur in form of acute or localized infection. I'll not take too much of time. Neurobrucellosis can occur in 2 to 7%, can occur in form of meningitis, encephalitis, myelitis, radiculitis. The usual mechanism is CNS infection with the organism or stimulation of the immune system. A brief word on the mycotic aneurysms. Staph, salmonella, strepto, pneumonia, earlier Treponema pallidum and Mycobacterium tuberculosis are the common cause. They're usually peripheral rather than peri-aneurysms. But we tried to look up the literature for reported Brucella aneurysm. Brucella is not very common in the area where we work, but it is much more common in the Middle East. If you can go through these charts, there is some predilection towards the basilar aneurysms. So basilar aneurysms and middle cerebral artery aneurysms are probably more common. And instead of the distal branches, although the case reports are few and few in between, the larger branches are involved more commonly than the distal branches. Another brief thing which I could pick up was the difference of pattern involvement between tubercular, brucellar, and pyogenic spondylodiscitis. So in areas where it is common, they have found that they have found that posterior involvement and dorsal spine is more frequently involved by tuberculosis compared to a lumbosacral spine, which is more frequently involved by brucella. So just a very, very brief summary. So between tubercular and brucellar spinal involvement, although in India we see all kinds of involvement. So this is from the literature from the countries where both the diseases are common. So site is more dorsal or dorsal lumbar. Typically the upper dorsal are involved more common. Psoas absence is more common in tuberculosis. Posterior elements are more commonly involved, and vertebral collapse is more commonly seen. However, our patient had a lower lumbar spine which was involved. These are my references. And these are my acknowledgements. I would like to acknowledge the Department of Neurosurgery, Intervention, Neurology, Microbiology, all my teachers, patients, and their family. Thank you.
Yeah, thank you, Dr. Neetu, for a very interesting presentation. Any comments?
Madam, you stop sharing so that I can start.
Yes, very interesting case. And for want of time, we moved with the second case.
The second case will be presented by Dr. Sunil Gashre about familiar cases of encephalitis. Please, Dr. Sunil Gashre.
Yes, can I start my screen sharing? Can you see me and hear me?
Yes, we can see you, sir. You can.
Yeah, your screen is there, Sunil. Yeah, go on.
Okay, then I'll go ahead.
Go with the slide presentation.
Sir, are there any video in your?
Sorry, I have videos. I do have videos. Can I go ahead?
Yes.
It seems it's not correct talk. On the screen is a case of movement disorders.
Yeah, but there is a twist. I'm from Jalgaon, Western India. We have the famous Ajanta Caves, a UNESCO heritage site, one of the treasures of India, one of the very many treasures of India. Well, let's move on. We had a 10-year-old boy who was brought by his mother for the complaints of difficulty in walking. He was becoming dull day by day. he had abnormal posturing of the neck and back. Although he had difficulty in walking, he did not have any falls. He was not going to school because he was becoming dull, and his teachers asked his mother to treat him and then bring him back to school. He was being raised by his mother, a single mother. His father was no more, had died a few years ago. Well, the symptoms started about a year ago and were progressive. He was advised admission, but he did not get admitted due to economic reasons. His father was a rickshaw driver and from an extremely poor background. There was no history of convulsions, headache, vomiting, or fever. His mother had brought him. His past records were not available. But his mother told me that the child had been immunized for BCG, oral polio, and diphtheria, pertussis, and tetanus. The mother, and now here is the thing which really foxed me. The mother and father both have the same disease as the child. The father died of this illness. The mother is asymptomatic. Neither is the father born of a consanguineous marriage, nor is the mother born of a consanguineous marriage, nor is the child born of a consanguineous marriage. Here, the mother told me that he had a normal delivery and normal milestones. Now, let us take a look at the two videos. This is the first video.
हाथ सरळ कर, हाथ सरळ कर, हाथ सरळ कर, सरळ कर हात, वर कर, वर कर, वर कर, वर कर.
तोडली रे, मान नाही ना, हात वरती करणार सोड.
ठीक आहे. चालून दाखव, चालून दाखव. हा हा, बसू नको, बसू नको, बसू नको, चालून दाखव. हा ये, माझ्याकडे ये, माझ्याकडे ये, ये माझ्याकडे ये, ये.
Would you like to look at the videos once again, or should I go ahead?
No, go ahead, Sunil, go ahead.
Okay. His general examination was normal. His cardiovascular, respiratory, abdomen were normal. His higher mental functions couldn't be tested very well because the child was alert, but his attention could not be sustained, and the child was uncooperative. The cranial nerves are normal. The eye movements showed mild nystagmus on horizontal gaze, but they weren't very well. We weren't very well able to test them. There was obviously no motor or sensory deficit. His reflexes were mildly brisk. Planters were downgoing. We could manage some cerebellar system examination. He had finger, nose, and knee heel ataxia. He didn't have any neck stiffness. At this stage, for a minute or two, would the experts like to comment? Because I had seen him in the OPD along with a few residents, and I was totally foxed. I didn't know what was going on. So would the experts like to comment at this stage? This case has been presented in the Movement Disorder Society and the Nimans group. So those who know the case may please not comment, while the others may please comment.
You said that the mother and father were similarly affected, or did I mistake that?
Yes, they were similarly affected by the same disorder. The father died of it. The mother seemed asymptomatic, and the child you have just seen. If you want, I can show you the videos again.
Now, was that the mother in the video?
Yes.
Okay, move on, Sunil.
Okay. Well, analyzing the case as a movement disorders person would do, because I'm a general neurologist, but into movement disorders, the phenomenology, localization, syndromic diagnosis, and finally the etiology. The phenomenology, there was neck and truncal ataxia, there was gait ataxia, there was difficulty in speech and some retropulsion. The child did have bradykinesia, but there was no limb myoclonus. But I will show you the videos again, but there was something going on in the chest, which we'll see once again. Now the localization, the higher mental functions were affected, the cerebellum was affected, bradykinesia, basal ganglia was also affected. So it seems to be an affection of quite an extensive area of the brain. Regarding the syndromic diagnosis, I was really foxed because the mother didn't have any papers, or she didn't want to show the papers. Father was an alcoholic, he had convulsions and he died. And the mother said that the father has the same disease which she and the son have. The mother is not yet affected and the child is what I have shown in the videos. Well, I could not come to a diagnosis with this history and with no papers or investigations. So I asked, I've seen him in the medical college, and I asked my colleagues or my residents around what they think, and they were as much confused as I was. And I got really very, very varied answers. Gersman, Stroessler, some environmental factor which is unspecified, which has caused the illness in all three people. Somebody suggested fatal familial insomnia. Somebody suggested progressive multifocal leukoencephalopathy, Creutzfeldt-Jakob's disease, progressive myoclonic, Lafora body, and mitochondrial encephalopathy. Now, I won't go into all of these details because of a shortage of time, and I'll go to the next slide. I was even more confused, and then I decided to investigate him. The routine investigations, hemogram, sugar, liver function tests, renal function, electrolytes, and urine were normal. Now, this is what I did, and this gave me the clue. The EEG showed bilateral slowing, theta to delta range. It was of moderate voltage, and there were periodic complexes. The MRI showed bilateral mild cortical and cerebellar atrophy. The MRI was done on 2 occasions, 3 months apart, but since the child also died later on and the mother was not traceable, I don't have both the MRIs. I have only one which I'll show you. And the CSF showed raised proteins, a sugar which was normal, and 5 cells or lymphocytes. This is the MRI, which the neuroradiologist said that it looks like cortical atrophy all over and probably some cerebellar atrophy. And well, it's a child and I'm not good at child MRIs, so we took his word for that. Now, has the penny dropped? Would the experts like to tell the diagnosis?
With the permission of the chair, I would like to throw my diagnosis on SSP. The truncal involvement, involvement is very, very common in SSP. The boy, you can see it is the extension of the trunk, which is very, very characteristic. So I will throw my bet on SSP. Sir.
Yeah, I would agree with that, but why would the father and mother have the same disease? That didn't make any sense.
Well, it didn't to me. Can I go back to the videos and Lakshmi is spot on the diagnosis?
No,
I'll just show the videos once.
Move with the case.
Okay.
There's a lot of time.
Okay. Wait a minute. Now this has got stuck. Well, I don't know. The screen has got.
While you're looking, I'll just make a comment. There's a phrase called chronic viral disease. It was termed by Sigurdsson, and there are a group of them that we see, including PML, SSP, progressive rubella encephalitis, even Creutzfeldt-Jakob, even though it's not a viral disease, was put into this chronic viral infection category. And the child sort of fits with this being some sort of chronic viral process. So
exactly. HIV and AIDS has a stigma in India. The child was HIV positive. He was born, the mother was infected by the father was dead, and the mother had given birth to a child which was HIV positive. She had hidden the history right from the beginning, as many patients do that. Then his measles antibody test was positive. The CD4 count was low, and the final diagnosis was AIDS, measles encephalitis, and SSPE. Although there are no definite myoclonic jerks, but there is a suggestion of the chest having myoclonic jerks, which we saw in the video. So it really foxed me, and being a neuro-infectious folio, I presented this case. Lakshmi, thanks for making a brilliant diagnosis, and you made it much before I could do it.
Sir, in fact, this is my observation. Sir, in fact, my observation was all the cases of SSPE which I have seen have spinal extensions. They all had the tilt backwards. The other common thing which are tilt backwards in the arms also going backward is Wilson's. The two things where the arms go backward, extended backward, and this trunk dystonia is, I have seen almost all the cases which I have observed. I have not documented, but I can, and I was, the moment you showed me the case, my first diagnosis was SSP.
Great, brilliant. I couldn't make it till I went through a battery of tests.
Berger would like to make comments?
Yes.
Well, so what's the evidence for this being SSP was what? You found
the EEG,
and
the measles antibody test, which is
the measles antibody was in the serum or in the spinal fluid?
Both.
You found it in both. Okay.
Yeah. And
well, then you should write this up, because I don't think it's been reported with HIV before. We will see myoclonus with AIDS encephalopathy, and you can even see spinal myoclonus. I've reported that, but this child didn't look like a typical HIV case.
Yes. And the thing is that many times they hide the history of being HIV positive because it's a stigma, and you just have to go on what they tell you, and then think till you finally come to a diagnosis. I think the child died after 4 to 5 months of presentation, and I thank FINE and the entire team, Kothari, Chandu, Khadilkar, and all the others. And I thank my son who has made these slides, who's in first MBBS at Lokmanya Tilak Medical College, Mumbai. Thank you very much.
Thank you, Sunil. Would Professor Jacks would like to make some comments, or we move to the last case and hand over to Professor Marian Visser?
Yeah, thank you. We already heard Dr. Lakshmi Narasimhan making a brilliant diagnosis. So we are looking forward to his presentation on a case of myelitis.
Can you see my slide?
Yes, Lakshmi, go on.
I'll go ahead without wasting my time. I don't want to waste. It's almost a similar case of what Madam has presented. A 42-year-old lady presented with low back pain, 2 months, fever with headache, 3 weeks, and altered sensorium for 2 days. The patient was apparently normal 2 months back. First developed low back pain and continuous dull aching.
Little louder, Lakshmi.
With no lower limb weakness. Can you hear me, sir? Can you hear me?
Yeah, it is fine now.
Yeah. She developed fever with evening rise of temperature and holocranial headache, admitted, evaluated from outside. CT and MRI lumbar sacral spine was performed, reported normal, continued to receive IV analgesics in the hospital. 5 days later, the patient's sensorium worsened and they were referred to our institute for further management. There was history of contact with tuberculosis. Husband is sputum AFB positive on DOTS therapy. Paucity of movements in both lower limbs was noticed. Bilateral knee and ankle reflexes were absent. Bilateral plantar responses were mute. Neck stiffness. There was no obvious spine deformity. Baseline electrolyte panel showed no obvious metabolic derangements. Urgent non-contrast CT brain revealed hydrocephalus. After taking sample for blood culture, patient was started on ceftriaxone and vancomycin. With the treatment, her sensorium improved and she was able to fully obey commands by day 3 of hospitalization in our institute. Her fever had completely resolved and she, however, continued to have neck pain and noticed her inability to move both lower limbs. Bilateral lower limb power 0/5 and inability to perceive bladder sensations and impaired sensations below T10. This is the first CT which was normal, and the subsequent you can see dilatation of the temporal horns. And you can see the diffuse litometrid pachy management with hydrocephalus, suggestive of meningitis. And in view of the hydrocephalus in our commonest thing, we suspected, and you can see this was the MRI on 29, and subsequently you see on 4/9 you can see the large longitudinally extensive transverse myelitis. So you can see the thing. So what is MRI spine? Long segment intramedullary hyperintense C3 to B12 with subtle pile and meningeal enhancement within the spinal canal, reflecting spinal arachnoiditis. So the meningomyelitis with meningomyelitis, the meninges of both cranial and the spinal meninges were involved. These were investigations. See, the AFB was positive. You can see the sugars were 12. The opening pressure was 220. The proteins were pretty high, and the cobweb was positive, and all other asthmatic profile, DNA profile, anti-DS DNA were all negative. So this is the cobweb. Still, because in our institute we have found that cobweb is a pretty sensitive test, forgotten but very, very sensitive. I have not seen a cobweb in any other, even a very high protein of other causes. There is no cobweb probably. There is something which is definitely the mycobacteria produces to produce a cobweb. So patient showed good response to ATT and steroids. Ambulatory within minimal 3 weeks later developed a no residual cranial nerve deficits. Just wanted to, for want of time, I didn't want to do any discussion. I'll just complete few things which I wanted to tell and have a discussion if there is anything later. The patient showed good response to ATT, and you'll be surprised that tuberculosis contributed to the extinction of mastodon. I don't know what COVID, but there are controversial also hunted the hunting theory, but more than that, the mammoth mammal, the extinction, one of the major roles is by tuberculosis. So I'm just going to tell you about why I presented this case. Is the longitudinally extensive transverse myelitis is pretty rare form of in the spinal involvement. I've read through all the series. The percentage is less than 8%. You can see it characterized by contiguous spinal cord, more than 3 vertebral segments. This series 2 case reports, and the rare neurological complication, the myelitis and the meningomyelitis, again the combination of involving the parenchyma in the brain, involving the myelitis, meningomyelitis patient. Meningoencephaloma combination is pretty common. Myelitis not there, and hello, and this was one of the reports says. You can see they were able to find only 10 cases of elitium in any cases of longitudinally extensive transverse myelitis. If you see, tuberculosis is not in the top of the list. It is somewhere in the bottom. The top ones will be occupied by NMO and all other vasculitides. The tuberculosis, even though it is rampant in our country, the presentation of LETM, in a presentation of LETM and in a presentation of myelitis, this is in the lower rungs. And the mechanisms of spinal cord involvement are many theories are proposed. This is by the Dastur and Wadia. They propose still holds good. edema of border zones of the cord secondary to impediment, pressure, meningitis, ischemic myelomalacia from vasculitis, post-thrombotic occlusion of the meningeal vessels, and infrequent infarction of the cord from vascular occlusion, formation of coalescent intramedullary tuberculosis, bony element involvement, spinal arachnoiditis, strangulating the vessels and the exciting nerves. And the largest series of spinal cord involvement in tuberculosis by Professor Garg and Gupta, where they have classified them into vertebral and spinal. Among the spinal, you can see the LETM comes lower down in this. And there also, the entire study, 147 patients, LETM was only in 8%. Median age was 31 years, male, female incidence. TB myelitis was associated with intracranial involvement. More than 80% had most common areas were thoracic and cervical. More than 50% had associated arachnoiditis, a very good response to ATT. Another interesting study is even in incomplete transverse myelitis, when not responding to steroids, there is a study which pilot study which showed that empirical ATT, which we all of us are practicing. Among the advances in the couple of things in the advances in the diagnosis which I want to highlight. You know that you must have seen that the CSF AFB was positive in our case. It's pretty rare because the very high viral load is essential or a very good expert is needed. There are two stains which use the Ziehl-Nielsen's and the Quignon. The sensitivity is only 20%. But we have an in-house neuropathologist who is now trained from NIMAX. She's doing the job. And that's why we were able to pick up this. And among the cellular things, the three important molecules, cell wall of the mycobacterium is peptidoglycan, arabinogalactone, and mycolic acid. Mycolic acid is 50% of its weight, and the lipoarabinomenon is one of the polysaccharide on the one of the lipopolysaccharide on the wall. I'm coming to that why I showing this. Sensitivity increased by 50% by do a high volume LP 10 cc, centrifuge it, extended slide examination 30, and expertise. All these things will definitely increase the yield of the AF in the CSF. Among the liquid media, you know, MGIT, mycobacterium growth indicator tube, culture has only 40 to 70% sensitivity and is not a gold standard like biopsy. The gene expert, mean time taken for a gene expert is 2000, which was approved in 2013 is 112 minutes. Sensitivity is only 50 and the specificity is about 95%. But on the nucleic acid application. What is recently what is used is expert ultra MTB, which takes 84 minutes. So on a given day, you can increase at least one test more. The next gene, it's a larger chamber, and there are a lot of studies have proven that it is slightly superior. And you can, as little as 113 case colonies, you can pick up by expert ultra MTB, which is approved by WHO in 2015. This is a study which is done the expert MTB ultra diagnosis. Where they have done in
we are going to have a full session on tuberculosis next month. So can you?
No, sir. I'm ending, sir. Another 2 slides. I'm ending it. Don't worry. There's a couple of slides. I'm ending it, sir. Just showing them the gene expert which we are using in our site and a comparison of the thing. This LAM, lipoarabinomenon assay, which is part of the cell wall, is very important, and this assay is also equally sensitive. So these are the two things which most of the institutes can start using in the diagnosis. The Zambia, they have conducted a study of comparison of all this. The CSF lipoarabinomenon has a very good specificity of about 94%. You can see that this is the study. And the conclusion said that expert TB has a specificity of 96, whereas LAM is highly specific in TB meningitis. And the metagenomic next sequencing is also equally good. And I'm just summarizing this. I'll just keep this slide. And I want to show this. This is a very important. If you see, this is a beautiful article in NEJM, where the various sites. This is the arabinoglycan. This is the mycolic wall, and the various sites. You can see the ribosomes, DNA various. Thank you. I have presented this case only that ATM first diagnosis is not tuberculosis. But even we got that tuberculosis, we worked up for all other cases. Will be only a diagnosis of exclusion when you have a LETM and meningitis, which gave us the hydrocephalus, which is pretty common in our country, and that is a Q. And the yield of CSF AFB was there. That's why it was. Thank you. Thank you.
I have not seen this kind of spinal presentation. I've only seen pot spine and pressure on the spinal cord,
The disc is not
destruction of the
involved. The
bone.
disc is not involved. The bone.
That is why we kept this case for discussion.
Yeah, yeah.
Yeah. Any comments from Joe Berger, Olivera, and before we close the session, final comments by Professor Raj Shakir about the whole series and moving.
My regards to Professor Raj Shakir. Nice to hear your voice, sir.
Yeah, all I could say, these were terrific cases. Certainly the case of SSP with HIV should be put in the literature somewhere.
Yes, I would do that. I would do that.
Send it to the Journal of Neurovirology. I'm one of the editors. It'd be a good one there if you want.
I'll do that. I'll do that. Yeah, it's well, Lakshmi says that he sees a lot of these patients and he hit the diagnosis. I had not seen it, but I would definitely send it. It's something which we don't see usually.
Yeah, well, I haven't seen a combination of HIV and SSP.
Yeah,
this was fun. Thank you, guys.
Yeah,
Thank
Professor Raj Shakir.
Yes, thank you. Thank you all. I think this is the end of the eight sessions that we've had in this series, and we hope to move to the new series next time. Again, fantastic cases, but each one of them deserves much more time, and hence to compress them may be a bit difficult for the speakers. But generally speaking, people have learned a lot from this series and the proposed topics for next series, and then the regional contribution from Europe, from North America, South America, Africa, and Asia will be very, very, very important, that we have the speakers from all these countries and the regional organizations are nominating their speakers. So all this is the work of Dr. Meshram and his colleagues, Gagandeep and Meshram. Thank you so much. And this specialty group is really the, I can say very clearly, it's the most active of the specialty groups in the World Federation. And I am honored to be, well, chairman of the group, secretary of the group, all kinds of things years ago. And seeing all this evolving is really very, very rewarding. Thank you all very much. I really appreciate it. And I think all the participants and all these people who remained to the last second of the last minute, 101 of them, are appreciating all what was presented today. Thank you so much. Thank you.
Thank you.
Thank you.
Good night.
Thank you.
Professor Akari Olivera would like to make some comments.
Sorry.
Professor Olivera.
Oh, I don't know if he's still on.
Yeah, he's there.
He's there. Okay. Oh yeah.
Thank you for the opportunities. Thank you, everybody.
Thank you.
I have no comments about this presentation. Thank you again.
Thank you. Thank you very much. Thank you for being with us. And thank you, Professor Jax, Professor Joe Berger, Professor Satish Chandra, and Professor Visar, and all the presenters. Thank you very much. I think it was a great session and you would have enjoyed it. Because of I'm sorry that because of technical issues, we had to start the session a little late. So we are ending a little late, but I think it was very interesting and very interesting presentation, and everyone has enjoyed. And from 26th of September, we start with the second series, and the first talk is on rabies by Professor Hemchuda from Thailand, and there will be cases from Thailand. And on 10th of October, we have, for the second series, we have breaks in between. On 10th of October, there will be a session on CNS tuberculosis, and Professor Suzanne Marais, who has extensive work in tuberculosis, she is going to organize that session. So we look forward to the series 2 from 26th of September, and Professor William Carol, WFN President, is going to inaugurate the series, and we hope to see you again on 26th September. The timing is little changed. We'll advance it by, rather than starting at 7 p.m., we'll start at 6:30 for the benefit of people from East Asia and Australia and New Zealand, because it gets late. So we'll start half an hour earlier. And thank you very much. Thank you once again, everyone, for being with us. And thank you, Professor Raj Shakir.
Thank you.
Thank you.
Thank you. Thank you.
Thank you. It's been great.
Thank you. Bye-bye.
Bye-bye.
See you.
Goodbye.
It was very good presentation about Hamilton. My friend.
Thank you very much.
Thank
for
you.
the support.
It was very good that you came, and your association with him has been so long, and it was very good that you were able
Okay,
to. Thank you.
I will try some Hindi words after
Yeah.
another time.
It was very nice to include those Hindi words. Thank you very much. And we enjoyed your hospitality when I was in Brazil, Sao Paulo.
I wait to have a good churrasco.
Yeah.
A good meeting. Okay.
Thank you again. Thank you. Bye.
Thank you. All right.